End of this session, I'll invite Dr. Rajesh Sinha, Professor RP Center, All India Institute. He'll be talking about the nucleus removal in presence of the corneal opacity.
At the outset, I would like to thank Dr. Harbanslal sir for inviting me in this course. I'll be talking about nucleus management in eyes with corneal opacity. Now, whenever you have corneal opacity or haze, the problem is the issue of visibility. And the aim of presentation is to discuss methods to enhance visualization so that we can perform the procedure appropriately. So first and foremost thing is the pupil should be well dilated. If you have a small corneal opacity in the center, you even with a mid-dilated pupil, in a routine cataract, if it's a 5 millimeter pupil, you can manage and you can go ahead and do the surgery. But if it's a small center opacity, in that case, you would like to have a larger pupil. So that's very important. Preferably should be done under periorbital block because sometimes you have to manage little bit of this thing. You may have to manage the iris and the patient might have pain. You can use intracameral drugs to reduce pain. And it is best performed when the opacity is only partly covering the cornea and in a nebular or nebulomacular opacity. We all use strap and blue dye for white cataracts, but in cases of corneal opacities, we should use it for a longer period because it not only helps in doing a good capsulorhexis, it maintains that stain even during the nucleus chopping. That's why we will not be, we will save the margin of the capsulorhexis while chopping if we see it directly. Another important thing is that if you have an opacity like this and you are doing a capsulorhexis, then when you are holding the capsule, you should not leave it behind the capsular opacity. As I'm trying to pull it beyond this opacity, bring it here behind a clear cornea and then hold it again and then complete the capsulorhexis. Another important thing is that you should do a very good hydro procedure in such cases. The nucleus should be nicely mobile so that you don't have any issue as far as chopping is concerned. Another important point is that in order to enhance visualization, you can use viscodispersive viscoelastic on the cornea. It's better to save the endothelium by using these chondroitin sulfate inside the anterior chamber, but on the cornea, when you put a viscodispersive viscoelastic, while you are chopping, suddenly it improves the visualization and you are in a better position to chop and you don't damage the capsule. As I said, OVD on the ocular surface, corneal surface is important. As I had mentioned earlier, if there was no opacity, even with a hard cataract like this, which is a black cataract, you could have managed with a 5 millimeter pupil. But if there's an opacity like this, in such a case, it's better to use a hook so that you can see the peripheral part of the nucleus as well and go ahead and do the chopping and complete the procedure. Another important thing to enhance visualization is the use of endo-illuminator. Endo-illuminator, which has been used in the retinal procedures, can be used in eyes where there is corneal haze. And you can ask the assistant to hold the endo-illuminator from outside so that while you are chopping, it will enhance visualization and you may not accidentally chop the nucleus. And once you have done the chopping and you are holding the epinuclear plate, you can take the endo-illuminator inside so that you can hold this epinuclear plate nicely and take it out and completely aspirate. So endo-illuminator is really very useful in managing such cases. Chandelier illumination in cases of corneal haze, sometimes sometimes you have even greater haze than this. Chandelier illumination gives a very nice glow and you manage it very well. I'll just show you another example of the use of chandelier illumination, wherein when you get a nice glow with the chandelier illumination, then you can see the rhexis margin while you are doing the capsulorhexis because you are getting a nice glow from behind. So that is very, very useful in cases of corneal haze. And when you are chopping also, you can see the nucleus pieces nicely under this glow that is coming from the chandelier illumination and go ahead and complete the procedure. If there is an opacity like this, And if you have a provision for a corneal surgery, you can definitely go ahead and do an anterior lamellar keratoplasty in this. You can remove this, cut it with a microkeratome, and once you cut this, you can see the opacity clears up, visualization improves. You can put viscodispersive viscoelastic on the ocular surface that will further enhance visualization. You can put trypan blue dye to further enhance visualization and go ahead and complete the procedure, and then of course put the donor tissue over the cornea to complete the procedure. Another situation wherein there is a very bad opacity, vascularized opacity, the other eye is thysical. You can see the opacity is more dense up to 80% of the cornea. So if you dissect up to 80% of cornea, you will be in a position to perform the cataract surgery nicely. And you can do a routine phacoemulsification, and then as you can see here, 80% of the cornea has been dissected. Now the visualization, as it was earlier, it was absolutely opaque, hazy. Now the visualization has improved significantly, and you can go ahead and complete the procedure with under direct visualization. So the basic aim of performing all these procedures is to perform it with good visualization, and the aim of this presentation was to discuss the methods to enhance visualization in presence of corneal opacity by using trypan blue dye for a longer period, so that you can, while chopping also you don't chop accidentally the rhexis margin. Use of viscodispersive OVD on the surface, use of endoilluminator or chandelier illumination, and lastly but not the least, in an opacity like this, if you have done a cataract surgery, you can do a small sphincterotomy in this area so that it doesn't come to the IOL edge also, and it will provide a small pupil adjacent to this, which will provide much better vision. And we had published this article long back in the year 2004, wherein the results had shown the patient showed very good improvement with those sphincterotomies. So thank you very much once again for this opportunity.